Good evening, everyone, and welcome to another BASH webinar series. Today, we're talking about how we do it in regarding to headache, and we have three excellent speakers this evening. We have Dr. Kay Kenneth, who's a GP with a specialist interest in headache, and she's going to tell us about migraine in pregnancy. We then have Professor Anne McGregor, who's going to tell us about menstrual migraine, and finally we have Dr. David Kenrick, who again is a GP with a specialist interest, and he's going to tell us about migraine in children. So first of all, I'll hand you over to Kay. Thank you, Kay.
Hi, good evening, everyone. Right, I'm just going to share my screen with you. We'll get the right presentation. So hopefully you can all see these slides. So thanks very much, Ben. Thanks for inviting me to speak this evening. And thank you all for joining us on an evening so sort of close to Christmas and quite a hectic time of the year. So I'm just going to speak for 15 minutes on managing migraine in pregnancy. And this is more from my perspective, where I work in primary care. So I'm a GP with a special interest in headache, and I work in Bradford. So this evening, I just want to cover a little bit about the pathophysiology of migraine in pregnancy, and then highlight two important cautions when we are managing people who have headache and who are pregnant. Firstly, the women who have pre-existing migraine do have a slightly higher complication risk in pregnancy. And secondly, the fact that headache in pregnancy is a little bit more likely than headache outside pregnancy to have a secondary cause. So we just need to be a little bit more wary. I'll talk about the medical management of migraine in pregnancy, which often causes confusion. And if we have time, I'll just discuss a couple of recent real life scenarios from my clinic. So the prognosis of migraine in pregnancy is generally good. Depending on which studies you look at, you see a 50 to 80% improvement in migraine. But unfortunately, if a lady hasn't improved by the end of her first trimester, it's quite likely that her migraine is going to continue throughout her pregnancy. So we do need to know how to treat it. 20% of women are very lucky and the migraine disappears completely in pregnancy. But 30% of women have severe symptoms. And they usually get worse during the first trimester. A few will develop de novo migraine in their pregnancy, and if that happens, it's usually migraine with aura. So if you're a person who suffers with migraine without aura, you're one of the most likely to improve. So we see about a 76% improvement in migraine. If you're unfortunate to be somebody who suffers with migraine with aura, you're likely to get worse, and we only see a 43.6% improvement. And ladies who have menstrual related migraine are actually more likely to improve. And then after delivery, return of migraine is more likely with bottle feeding compared to breastfeeding. So breastfeeding seems to maintain stable estrogen levels. They're low in breastfeeding as opposed to high in pregnancy. So that can be helpful. Younger women also are more likely to return to getting worsening migraine. So what's happening in pregnancy? Well, there's loads of hormonal changes. So pregnancy is represented here in the shaded section in the middle. And we know that the trophoblast releases HCG when a lady becomes pregnant, and that allows the corpus luteum to produce estrogen and progesterone. And then the placenta takes over and produces the estrogen and progesterone after that, and the levels become really high. So by the third trimester, you tend to see 30 to 40 times the usual estrogen level and about 20 times the usual progesterone level. And you can see in grey on the bottom of this chart that the incidence of migraine, and this is migraine without aura, really drops down during pregnancy. But then as the levels of estrogen and progesterone drop very, very sharply from stable high levels, they suddenly drop at delivery and during the sort of first 6 weeks after birth. The incidence of migraine peaks up again, and women do tend to return to their pre-pregnancy levels of migraine after that. So it's always been thought that the high stable estrogen seems to be protective against migraine without aura. But unfortunately, it does seem to increase the risk of migraine with aura. And we're not sure exactly how that happens. There's probably a hormonal influence on cellular excitability in the cerebral vessels. And the hormones, the estrogen and progesterone, cross the blood-brain barrier, and some can be produced in the CNS. So there's a lot of hormonal influence going on there. But it's definitely not simply the estrogen levels, and there's lots of work ongoing looking at other factors that might be involved, such as oxytocin. And we also don't know why some ladies are much more prone to getting migraine worsening or starting in pregnancy, whereas other ladies are not. It's likely related to different abilities in different ladies to metabolize the estrogen and progesterone and other hormones. And certainly we have seen evidence of genetic polymorphisms. So looking particularly at the genes coding for sex hormones and their receptors, you can see there's a correlation between certain polymorphisms and an increased incidence of migraine attack. But there's likely to be loads of other factors as well, including the fact that in pregnancy there's more muscle relaxation, there's a reduced hypoglycemic response, there are emotional changes. So there's lots going on, and it's still an area of lots of research. So when a lady comes to speak to you, I think it's a bit sad in primary care now. We're so busy that it's really rare for me to see a lady come in and just say, well, I'm thinking about getting pregnant. Have you got any advice? So preconception counselling, unfortunately, it's not frequently and commonly done, but sometimes we can do this opportunistically. So if I'm seeing a lady and I'm taking out an implant or I'm taking out a coil and she's wanting to get pregnant, it's a really good time to ask about headache. And I think it's for any primary care clinicians who are out there listening to this, it's really useful to ask about headache at that point. If somebody's getting frequent headaches, we need to think about anxiety and depression, because they can be associated with frequent headaches, and it's a really good time to get on and help manage that before the lady becomes pregnant. And always try and specifically ask about migraine. Some people feel that ladies with migraine with aura should have specialist obstetric care. And the reason for that is that migraine with aura is associated with an increased vascular risk on top of an already prothrombotic risk, which you see in pregnancy because of the high estrogen levels. So a pregnant migrainer is at increased risk of gestational hypertension. She's at increased risk of preeclampsia, so 1.8 times the background risk. And that increases further if the lady has other risk factors, for example, a raised BMI or an older age. And she's also at increased risk of vascular complications in her pregnancy, including ischemic stroke, MI, and thromboembolism. There's a higher risk for ladies who become pregnant and see no remission of their migraine or worsening migraine. So it's really important to be cautious in pregnant ladies with migraine. If they come with headache in their pregnancy, we always do a blood pressure and a urine dip. We do that anyway, but being particularly careful to do that in people who have migraine. So there are lots of secondary headaches that we see in pregnancy. So it's vital that you take a clear history and investigate and admit if needs be. So the causes of secondary headaches that we see in pregnancy are eclampsia, more common in migraine, stroke, up to 6 weeks post-delivery, and again, more commonly seen in ladies with migraine. We see post-dural puncture headache, but that's normally pretty straightforward and easy to diagnose. Cerebral amyloid angiopathy bleeds into the pituitary, thrombocytopenia, cerebral venous sinus thrombosis, again, more commonly seen in migraine, often presenting with a thunderclap headache or with raised intracranial pressure. Subarachnoid hemorrhage, we see that more commonly than background when a lady's in the 3rd trimester of pregnancy, when her maternal output peaks. We see more RCVS in pregnancy, and that can often present postnatally. And we see more posterior reversible leukoencephalopathy in pregnancy. So anybody coming with a headache that isn't fitting with their usual characteristics of migraine. If they don't normally get migraine, or if it's different to their usual migraine, then we need to be alert and investigating further. And I know that even in secondary care, there's often a reluctance to image pregnant ladies because of fears to the developing baby. But it's very clear that we shouldn't be delaying CT scans if there's a good clinical indication to do that. The radiation dose is really small with shielding. And there was a good study from JAMA in 2016 showing MRI is safe in pregnancy, but we shouldn't be using gadolinium. So how do we manage pregnant ladies who do have migraine? Must always remember the basics: regular food, fluids, exercise, stress management, regular sleep-wake cycles, reduce caffeine, trying to manage any alcohol or smoking. And generally we would try and avoid medication unless it's needed. Paracetamol is perfectly safe. But then on the other hand, we do need to be aware that many women will need medication in pregnancy, and we shouldn't be afraid to prescribe it. And I always explain to the lady that just because a medication is not licensed in pregnancy, it doesn't mean it's harmful. Obviously, you do need to discuss risks versus benefits, and you need to document that discussion. And a website that I use a lot is this, the BUMPS website, which is fantastic. You can type in the medication that you want to prescribe, and you can print off a patient information leaflet then and there for the lady. So the acute medications for migraine, paracetamol is your first choice, and it's safe. Non-steroidals, even up to doses of 600 milligrams per day, can be used, but we don't use non-steroidals after 30 weeks because of the risk of failure of closure of the ductus arteriosus. And we've got quite a lot now of good safety data for triptans, particularly sumatriptan, which also seems to be very safe. Aspirin we would avoid in the second and third trimesters, again because of failure of closure of the ductus arteriosus, but also slight bleeding risk. Antiemetics are mostly safe. Cyclizine and promethazine are usually first line. Just need to be aware of the small risk of tardive dyskinesia with promethazine. Prochlorperazine's got less data, but no evidence of harm. And metoclopramide and domperidone also have good safety data, and because they reduce the gastric stasis, that can have a dual benefit. We've got to be aware again with the metoclopramide of the small risk of dystonic reactions and the small risk of arrhythmias with domperidone. But we don't use opiates, as we wouldn't in non-pregnant migraineurs either, but particularly in pregnancy because of the risk of neonatal withdrawal and respiratory depression. And sometimes prophylaxis is needed. And propranolol and amitriptyline are used very, very commonly, really good safety data. The first line is probably propranolol using the lowest effective dose. We do monitor blood pressure. There are potentially some small risks when you look at big studies, but a lot of the ladies who are put on propranolol are put onto it for cardiac problems and not for migraine. So the potential sort of risks of congenital heart defects, intrauterine growth retardation, low birth weight, possibly not seen in migraine. It's unclear whether we should stop the propranolol between 24 and 48 hours before delivery, because in theory you can get some hypertension, respiratory depression and distress in the newborn baby, but it's not usually seen in clinical use. Low dose of amitriptyline is safe, but again, stop it before delivery, 3 or 4 weeks before delivery, because it can affect the baby. They can get tachycardia, irritability, muscle spasms. We must not be using topiramate, candesartan or sodium valproate because they're all teratogenic. And if we are considering prescribing those in a lady who does have pregnancy potential, we've got to really clearly document that we've explained that. We don't have safety data for some of the herbal things like coenzyme Q and riboflavin, so I would avoid those. But low-dose magnesium supplements are considered safe. Unfortunately, we have to avoid the CGRP monoclonals. We've seen quite high incidence of spontaneous abortion and congenital abnormalities, including anencephaly with some of the CGRP monoclonals. And because they have such a long half-life, we should not be giving, we should be advising our ladies on these not to become pregnant for 6 months after treatment. There's no evidence of harm from the transdermal stimulators or from greater occipital nerve blocks or from Botox. So in summary, migraine would tend to improve in pregnancy, particularly migraine without aura. We need to be aware to further investigate headache if it's new or different from the usual migraine, remembering that women with migraine are at increased risk of vascular complications. And while we aim to minimise pharmacological treatment, many medications do have good safety data. So I think that's been about 15 minutes. So maybe we'll just pause there and see if there are any questions or queries. We can come back to some cases if there is time. I'll stop sharing. Oh, can't quite hear you, Dr. Wickett. Yeah.
Thank you very much, Kay. That was a brilliant summary of migraine in pregnancy. We've got a couple of questions. The first one is aspirin. What dose of aspirin is allowed in pregnancy, presumably for pain relief?
Yeah, I mean, the obstetrics use sort of higher doses, don't they? We would say sort of you can use aspirin sort of 600 to 900 milligrams, but I would probably avoid it I would avoid aspirin in pregnancy myself. The obstetricians do use it a lot, don't they? A few of my ladies, they've been putting on sort of 75 or 150 and using that as prophylaxis, but it's not my favorite. I don't know what the rest of Anne might have some better insight into that.
No, not really. I mean, I'm well aware that they will often use well, some of the obstetricians use 75 milligrams low dose for migraine prophylaxis, but that's not usually done by the migraine specialist. So I think there are differences in different specialties and depending on what you're treating. So
no, exactly. The second question is what advice for contraception when on topiramate?
Okay, yeah, so this is a really hot topic, isn't it? Because traditionally we were told that you could use low doses of topiramate and it wouldn't be an enzyme inducer, but the Faculty for Sexual and Reproductive Healthcare have updated their guidance, and we've just seen a lot more studies showing that it really is incredibly teratogenic, is the topiramate. It can cause congenital abnormalities and it can cause sort of neurodiversity as well in kids. So I think we're going to be using it less and less, aren't we, now that we've got the CGRP monoclonals in women of childbearing potential. But the Faculty of Sexual and Reproductive Healthcare still say that it's fine to use either of the two coils or the Depo-Provera, because they would the hormone levels would not be affected by the topiramate. Because you avoid the first pass through the liver with the Depo and with the coils, so they're safe. So I wouldn't prescribe topiramate anymore unless a lady with childbearing potential was on the Depo or the coil.
Okay, and one final question: if you have a lady who presents in pregnancy with worsening headache, are there any green flags which help you reassure the patient that this is migraine rather than anything more sinister?
Yeah, I think I struggle with this green flag concept. I know it's becoming really popular. I mean, I think it's important that 90% of women who come with headache in pregnancy are not going to have a serious underlying cause, but 10% of women might do, and you've got to dig around for that. But I think a lady who comes with their normal migraine and just getting more of it is not of concern, and particularly if they're having headache-free days in between their migraine attacks. You're pretty certain then there's nothing else sinister going on.
Excellent. Right, I'm now going to hand you over to Professor Anne McGregor, who is a specialist in headache and sexual reproductive healthcare. And this evening, she's going to tell us about menstrual-related headache. Thank you very much, Anne.
okay, thank you very much, everybody. Let me just share my screen. So I'm just going to, over the next 15 minutes or so, just take you through a practical guide to menstrual migraine. So nowadays we have to show all our disclosures, so here they are. But moving onwards, I think the real issues are the women who come along saying that it's all their menstrual periods that's the problem. They know it's their periods that trigger their migraine. But how do we really tease it out? Because obviously there's always a lot of other things that are going on. The first thing really is, how do perimenstrual attacks differ from menstrual migraine? And this was a study that was undertaken in Leiden, and it was looking at 500 participants who were using an e-diary. 998 of them there were 998 perimenstrual attacks recorded versus over 4,097 menstrual attacks. And these were attacks that were recorded between days -2 and days -3. Now, the first thing that you can notice in this violin plot is really the differences in attack duration between perimenstrual and non-perimenstrual attacks. And the differences were really driven by those women who were given a diagnosis of menstrual migraine. And I'll come on to how we do the diagnosis in a minute. Where for the perimenstrual versus non-perimenstrual attacks, there were statistically significant differences in associated symptoms as well as the duration, particularly with respect to photophobia and phonophobia. No differences in nausea or vomiting. Women, the menstrual attacks in women diagnosed with menstrual migraine were unlikely to be with aura. They were more likely to use analgesics and triptans. And even while they got a good headache response and a good 2-hour pain-free response with treatment, they were more likely to experience recurrence of symptoms both within 24 hours and within 48. Whereas if we compare perimenstrual versus non-perimenstrual migraine attacks in women without menstrual migraine, the only real difference we see in the menstrual attacks is that they also are more likely to recur within 24 and 48 hours. So there are differences in all women with menstrual attacks, but the differences are far greater in those women with a diagnosis of menstrual migraine. So that leads us on to, what is menstrual migraine? Well, menstrual migraine, if it's properly diagnosed, should be where perimenstrual attacks are occurring more often than would be expected by chance association. And in these women, we can be more sure that the menstrual attack is, menstruation or some effect of menstruation is driving the attacks, whereas and different from attacks at other times of the cycle. So how do we go along and diagnose them? Well, what about self-reporting? Because many women are coming along and saying, oh yeah, I definitely have menstrual migraine. I'm not going to go into all the data from clinical trials that show that self-reporting of migraine is rarely a useful diagnosis. And when you compare it with objective data, subjective diagnosis of menstrual migraine is rarely the same. So ultimately, prospective diaries are absolutely mandatory when making a diagnosis. And the diagnosis is really simple. The International Classification of Headache Disorders does have diagnostic criteria, but they are really there more for research purposes than they are for clinical practice. And in clinical practice, all you need to do is get the woman to keep a very simple diary, and you can very clearly see a huge amount of information just from a simple diary such as I'm showing you here. So every single day of the year has a box associated with it, and all the women a woman needs to do is put down a cross for a migraine attack and a circle for a day of menstruation. So this diary, just by virtue of the diagonal line, if you like, that you can draw through the menstrual periods, we know that she's having relatively regular menstrual periods. We can also see from the crosses that she gets migraine with menstruation and at other times of the cycle as well. But those attacks that she's experiencing with menstruation are lasting longer than attacks that she experiences at other times of the cycle. So she pretty clearly is experiencing menstrual attacks of migraine. But what about if we alter the diary slightly and we have a woman who's got more high frequency episodes of migraine? And here, while it's essentially exactly the same as the previous slide, the difference is we've added more migraine attacks. And in these cases, it is pretty difficult to make a diagnosis of true menstrual migraine that might be more than a chance association. So I would not consider a diary like this to be something that you would want to treat as menstrual migraine. So what causes menstrual migraine? Well, the first thing to say is that it's not purely hormonal changes. And as we see in all migraine attacks, it's a combination of various trigger factors that will affect normal brain function. And when they gather together and cross the migraine threshold, then that triggers off a migraine attack. So the first thing to emphasize here is that you might want to look at the non-hormonal triggers before you start considering whether the hormones actually need to be managed. Of the studies that have been done, there is such a paucity of research that is done in this situation. The only one that has been shown to shift reproducibly and not necessarily even require menstruation has been the drop in estrogen during the late luteal phase of menstruation and the pill-free interval of combined hormonal contraceptives. And these estrogen withdrawal times are both times that we see an increased risk of migraine. And if you remove the estrogen withdrawal, you prevent those attacks occurring. If you shift the estrogen withdrawal to a different stage of the menstrual cycle, it still reproducibly triggers attacks. So when we're looking at other factors like oxytocin that Kay was mentioning earlier, we do need to ensure that it's not just because they're occurring in the late luteal phase. We also need to see that there is a phase shift if it's going to be implicated. And certainly with respect to estrogen withdrawal, these episodes almost invariably trigger a migraine without aura. But menstruation is also associated with other factors that we've seen increase the risk of migraine. So women who have very painful and heavy periods, so menorrhagia and dysmenorrhea, we also see migraine associated with it. And by treating the painful heavy periods, it's been shown that this also treats the migraine as well. The other factor to be aware of is that migraine is a risk factor for the onset of menopause symptoms, and this risk is statistically significant. And that really mirrors the typical population that we see of women experiencing menstrual migraine in their natural cycles are typically women in their early to mid 40s, and they progress through menopause and gradually decline with time. So management, the first aspect of management is to optimize acute treatment. And it is always important to ensure that women are actually taking their treatment in the correct way, it always startles me the number of people who still delay taking triptans, for example, because they don't want to waste them or they want to be sure it's a migraine, and that minimizes the likelihood of them being effective. The other factor is that many women feel that they can't repeat the dose, so they wonder when the migraine comes back again, what they're supposed to do about it, under the misconception that a single dose is supposed to treat an attack, whereas a single dose will only be effective for the duration of efficacy of the treatment, and that may be much shorter than the duration of the attack. So they may need to dose for 4, sometimes even 5 consecutive days. For high frequency migraine attacks, obviously do consider standard prophylaxis. But what about managing the hormone trigger? Well, if the trigger is the hormone-free interval of combined hormonal contraceptives, that is very simply managed with taking the combined pill continuously. And Faculty of Sexual and Reproductive Health Care are very clear in their guidance that continuous use or extended cycle use is a perfectly acceptable way of prescribing the combined pill, irrespective of how it's packaged, and indeed will also improve contraceptive efficacy as well. So quite routinely now, we prescribe combined hormonal contraceptive without a break at all, because there's no scientific evidence to support that break. With natural cycles, if a woman has a menstrual disorder, the obvious thing is to treat that first of all, and then consider if there are still issues that need to be managed with respect to menstrual migraine. The other factor I've already alluded to is to consider perimenopause. And so consider these factors in women who are reporting or ask about changes in cycle length, changes in menstruation, new onset anxiety, because anxiety is a very overlooked menopause symptom, new onset sleep disruption, which obviously also goes hand in hand with migraine, and vasomotor symptoms, which in early perimenopause may just be occurring premenstrually rather than throughout the entire cycle. So the good thing is that in women, particularly the more hormonally driven it is, we can assure them that there is likely to be improvement in migraine without aura with increasing time post-menopause. And that makes it even more important to ensure that treatment we give them is safe and not going to cause any long-term problems, because the natural history of the condition is to improve. So to summarize, key points is that migraine is affected by the menstrual cycle in all women, but more so in women with a diagnosis of menstrual migraine. Most women, even those with menstrual migraine, will benefit from effective standard acute and prophylactic strategies. And hormonal strategies should be targeted to underlying mechanisms and comorbidities. And at that point, I will leave it there and wait for any questions.
Thank you very much, Anne. That was excellent. Just while I'm waiting for some questions, I've got a couple of my own actually. HRT, is that, when you mentioned the combined oral contraceptive pill, is that being used as HRT?
Increasingly so, because women are naturally healthier. I mean, the important thing to be aware of is that combined hormonal contraception with respect to migraine, the contraindications or UKMEC criteria, or the guidances that we use for prescribing contraception or contraceptive pills really relate to contraceptive use only. The guidelines for medical eligibility criteria are very, very clear that they do not cover medical use of contraceptive hormones. So obviously safety should always be a factor, But in an otherwise healthy woman, including a woman who has migraine without aura, combined hormonal contraception can be used up until the age of 50. Now, there are also a couple of pills that are on the market that contain the same estrogen that is used in HRT, so estradiol. And the particular one that I will tend to use is Zoily, and I can mention its name because it's the only one that is a monophasic pill that contains estradiol that's currently available. So while even oral estrogen, oral body identical estrogens, estradiol, will still make the blood slightly more sticky than a transdermal estradiol, the stickiness is not as great as associated with ethinyl estradiol, and there are publications, or a publication certainly that should be coming out from a colleague in Belgium that compares the venous thrombotic potential of Zoily compared to other standard contraceptive pills. And the future is even brighter because we will be having E4 containing pills which do not increase clotting parameters at all, which obviously could also be used as contraception.
Excellent. So with migraine aura, it's not uncommon for women in their 50s to get migraine aura without headache for the first time. Has this got anything to do with menopause?
Probably not. It's more related to atherosclerotic events or changes in the way that blood vessels function post-menopause. That said, during the reproductive years, it's very clear that high levels of estrogen are associated with aura. We see it during pregnancy when aura can occur for the first time. We see it when women start hormone replacement therapy, particularly during perimenopause, where it started too early and estrogen levels can spike very high. That can trigger off migraine aura as well. But post-menopause, obviously estrogen levels are low. So there's got to be other factors that are involved. And we're aware that aura is associated with sometimes with clotting disorders as well. So there's something vascular that will likely to be associated with that.
Brilliant, thank you very much. So our last talk is from Dr. David Koenig, who's a specialist, a GP with a specialist interest in headache, and he has run the Exeter Headache Centre for many years. I know as a registrar I used to plagiarise lots of the patient information sheets that he has on his website, and I continue to use them now. So David, over to you. Thank you very much. You're going to talk about migraine in children.
Thank you, Ben. Thanks for inviting me this evening. Perhaps we could start, sorry, let me just put my full screen on. I'd just like to start with the looking at the incidence, just to remind ourselves that migraine starts in quite a young age, in fact, boys slightly earlier than girls, but the maximum age of incidence is in the early to mid-teens. So I think it's important to realize it can be quite a frightening area. When you get aura for the first time with a headache, you think you're having a stroke, and I think for a lot of children this can be quite frightening. One of the problems in this area, there are huge numbers of challenges. First of all, there are poorly addressed needs. Let me just define needs and wants. So needs is what a healthcare professional thinks will benefit a person, whereas wants is what the individual person thinks will benefit them. And as I will demonstrate, the needs of children with migraine are very poorly addressed, and there are also incongruent wants. But unfortunately, there are also limited therapeutic options in an area where there is a very significant lack of an evidence base. So let me just illustrate the impact of headache in young people. This is a study we did in Exeter in one of our local schools in 2009. We looked at over 1,000 school children, and 20% had a significant impact of headache. On the average PED-MIDAS, this actually sums the number of days where their function is reduced 50% or greater in a 3-month period. So they had 12 days in which they were functioning inadequately in a 3-month period, but 10% of this group that we looked at had a very high score of 16.8. And in fact, their generic quality of life score, the PEDS-QL4, scored at 70, worse with children with other quite serious diseases. And in fact, we've just this week reanalyzed, we've done the survey again, another 1,000 school children, which we've reanalyzed. And interestingly, the results are absolutely identical. So nothing has happened in over a sort of 10-year, 12-year, 13-year period. So I think that really demonstrates the impact that this problem has on young people. And this really maps on to the work of Ishaq Abu Arafeh, who also suggests that 20% of children have severe headache. And the bottom dark grey column is migraine. And you can see that the majority of cases of migraine, and I think probably most of this is migraine right across the age group. It's just more easy to diagnose as you get older. So again, this sort of maps onto what we are suggesting, that about 20% of the young person's population have a significant problem with headache, the majority of which is going to be migraine. So we actually follow this through, and we look after our practice, look after the University of Exeter. This is quite an old slide now, but I bet my bottom dollar that this hasn't changed at all. We managed to nab 94% of all the first years in Exeter University, and there's this 20% figure that's coming through. They had 20% of had headache that bothered them. Less than 50% had prescription medication. So probably most of these people hadn't seen their GPs. So let's just say a little bit of something about headache. In children, it's often so-called mixed, although I very rarely make a diagnosis of tension-type headache. I think it's mostly migraine, more likely to be bilateral. It's shorter, associated with all these other problems, particularly abdominal pain. Is recurrent abdominal pain is quite a significant problem. And the majority will go on into adulthood. We don't know whether treating them early will impact this transition. I suspect it will, but what we do know is that even if you do treat them early, there is at the moment no evidence to suggest what happens to them as they go on into later adulthood. So I want to split my talk into two. First of all, I'm going to look at treatment in these three areas, but I actually want to focus also on diagnosis, because I'd like to take away that my sort of message is that unless we diagnose them, and only about, I reckon, 10% of children and young people with migraine are diagnosed, they could be storing up problems for later in life. So we've got to diagnose them before we can treat them. So I think in this age group, diagnosis is equally as important as treatment. So how are we going to treat them? Well, basically, you can treat young people and children as many adults. The principles are very similar. They are more sensitive to changes and things. They seem to be more sensitive to triggers. And clearly, the developing brain is more sensitive to the psychosocial factors that are impinging upon them at a very crucial age. So we might like to focus on diet and exercise, stop all the fizzy drinks and the drinks with stimulants in them. Screen time is an important factor. Focusing on sleep hygiene, make sure they get adequate sleep, avoid triggers. They're all eating crisps and all this junk food. And I think this keeping things as regular as possible is important, particularly in this age group, regular breakfast and hydration. In this study we've just done of 1,000 school children, we asked them whether they ate breakfast regularly or whether they hydrate themselves through the day regularly. And quite large numbers are not having breakfast and not hydrating, 3% both. So 25% are actually having inadequate fluids or skipping breakfast. And we found that this correlated highly significantly with frequent headaches. So these are very simple interventions. We're not talking about rocket science that will make big differences in children. We're talking about simple interventions. Some time ago, I put together an influence diagram. This is a bit of a complex diagram, but it just shows the way these psychosocial factors are moving based on what evidence there is available. And you can see there's lots of complex stuff interacting here, which impacts upon children's headache, which then impacts upon their school performance. They get more bullied, their school performance gets worse, they don't sleep. And so it goes round and round in circles. So they're far more sensitive to these complex factors. And then there's these coping mechanisms and the fact that their parents probably have migraine and they know when to see the doctor. So there's this health-seeking behavior that's imprinted upon them. So it's a really complex web to unpack. But I think if you can start looking at these sort of factors, you're a long way towards helping these children with such significant problems. So what about medical treatment? Well, when we've addressed the lifestyle, when we try to unpack some of these complex psychosocial issues, let's look at acute medication first. And this is what we have in our armamentarium. Paracetamol is our mainstay. Ibuprofen works well in children. Cyclizine and metoclopramide are the antiemetics of choice, and it's very rare that children are actually treated with antiemetics. And as I'm sure you're aware, due to the problems with very high placebo responses, statistical significance has only been achieved with nasal sumatriptan, which is licensed down to the age of 12 years of age. Children don't like it because it doesn't taste very nice, but nevertheless it is useful in most cases of children's migraine. There's no reason why you can't use oral sumatriptan. There's huge amounts of safety data with oral triptan. It's just not licensed because a significance could not be obtained against placebo. And it's similar with the other triptans. These are the 3 triptans where there is 1 or possibly 2 small randomized controlled trials. I think amitriptan is actually licensed in America by the FDA in children. Amitriptan nasal probably works quite well, but they're not licensed in young people. But I think you can use oral sumatriptan quite safely, 50 milligrams, down to the age of about 7. I think if you're a GP, you need to refer them on to secondary care, but there's a lot of safety data to support oral sumatriptan, and in some children it can be effective, but you're always fighting this big placebo response. What about preventative medication? Well, I find pasotafen really useful in children. I find it doesn't work. In fact, I rarely visit it in adults, but in children it is very effective. Weight gain is obviously a problem, but I think certainly that's the first port of call, particularly for general practitioners who I think are very familiar with that drug, and I think they feel quite comfortable using it. Other drugs that are recommended are propranolol, amitriptyline, and topiramate. And for specialist practice, we may think about flunarizine and occipital nerve blocks. I alluded to the fact earlier that prevention, it has no evidence base, or there is very little evidence base. And in fact, there's one study which was rather awkward in prevention, and this was an American study where they looked at placebo against amitriptyline and topiramate, which are the 2 most commonly used drugs for pediatric migraine prevention in America. And these 3 columns show different methods of analysis. But as you can see, there's absolutely no difference between amitriptyline, topiramate, or placebo. And this left all these specialists in a rather difficult position. It's very interesting. It hasn't really changed management at all. So on one hand, we say we must stick to evidence-based medicine, but when the evidence comes up with results that we don't actually like, we tend to ignore it. But that just demonstrates how difficult it is to move forward in this area. Pharmaceutical industry are not particularly keen on doing studies in children, so I'm not sure that we will ever get a better evidence base, although I think there are some studies with CGRP drugs underway at the moment. So really that's all I want to say about treatment. It's fairly limited, fairly straightforward, but even making the diagnosis, taking the child and their parents' concerns seriously and offering some simple interventions can make a very big difference to these children's lives. I want to go on now and talk about something I'm really quite keen to stress, and that's the importance of diagnosis, because if you don't get them diagnosed, you're not going to get them treated. And I like to see life as living on the exponential curve. We live in the law of diminishing marginal returns. So as we put more resources or interventions into something, we get a very huge benefit to start with. And then as we put more and more resources into it, the benefit tails off. And in children's headache, children's migraine, we're actually probably dealing with right down the bottom of this curve. So even the smallest amount of intervention will have very significant impact upon these people's lives. So I think the important thing for me is let's get them on the curve to start with, and then we can worry about treatment afterwards. Anything you do then once they're on the curve is fine. And I think one of the important things about this is this concept of allostatic load. I think this is a really interesting concept, that with many of these inflammatory conditions that are recurrent, you get this stress load building up over time. You get yourself into this positive feedback loop. So this headache that starts, this migraine that starts in young people, if it's not treated adequately, builds up and builds up and builds up. So when they finally come into the system, we're dealing with these really expensive CGRP drugs, whereas possibly if we dealt with the issue early, if we made the diagnosis and gave them a locus of control, started some treatment, they may not go down this vicious cycle of increasing allostatic load. So I think it's a really important area and a really interesting one. So what's actually happening out there to children? I've done quite a bit of work in primary care around the children's agenda, and the best estimate is about 10% of children with headache will actually see their GP. When they see the GP, 25% will get referred, only 4% for adults. So this is reflecting really the uncertainty of GPs in dealing with young people. When they don't refer them, and when they actually make a diagnosis, only 20% of children will actually get a diagnosis by their GP. When they get a diagnosis of migraine, only 3.5% will actually get a triptan, and 21% will have some sort of preventive medication, usually pizotefen. This was an interesting study we did a few years ago. We have a big practice at St Thomas's, so we wrote to all 2,500 children and said, look, do you have headache? If you have a problem, we've got a clinic here, come and see us. We'd like to see you. We give them the ideal opportunity. You've got a nice car park, they knew us all. We know that 20% of those children have headache that impacts upon the quality of their lives. 3% of those children actually accepted the invitation, or their parents accepted the invitation. Only 2% attended, so a third didn't even bother attend. And when we actually saw the children that we did, they had quite a high impact overall, 6 days a month of impact of their headache and 1 day of school lost on average. And we found that with even the most simplest of interventions, mainly advice, paracetamol and pizotefen, we found a significant improvement in their scores, their impact scores. So for some reason, they don't want to come forward, but when they do, we can make a really significant difference. So in conclusion, estimates are less than 20% of children with migraine will consult, high referral rates. And if we assume all the referral rates are migraine, and we can give a diagnostic 50%, it's a lot lower than that, of those that GPs don't refer, you can assume that only 10% of the young people out there with migraine actually get diagnosed. And this could be a significant risk to their allostatic load. So I think my parting thought would be, let's just get these young people on the curve and not worry too much about treatment, because whatever we do, there's going to be a very steep benefit. The important thing is getting the diagnosis right. Right, Ben, that's a quick whip through of headache in children. You're muted, Ben.
Thank you very much, David. Just while people are tapping away with some questions, I just wanted to ask something. Do you think that, I mean, I know my children spend a lot of their time on their phones and in front of computers, probably more than I did when I was younger. Do you think that we will see increased migraine in the future because of things like screen time?
I think life's getting more stressful for children apart from social media is certainly, it's not just the screens and the sort of effect on their hypothalamic axis, but I think it's the actual social media as well, which is causing increasing amounts of stress, psychological stress, and the pressures on them at school, more and more competition to get to university. So I think the general milieu of life in where we're living is increasing on these children, which will reflect in increasing rates of migraine.
I mean, I think the interesting thing about migraine is, especially when you're young, I mean, I had migraine when I was a child, and I sort of suffered in silence because neither of my parents had migraine and they didn't really know what it was. And it all boils down to education, doesn't it? If you're with other people who don't know what migraine is and they just say, oh, it's a headache, then, you know, as a child, you just go forward thinking, oh, it's just a headache, but it's clearly not. And it's just interesting how we can sort of, you know, how can we improve the education of migraine in schools and among parents?
Well, this is my big focus, Ben. At the moment, I've just applied for a grant. In fact, whether I get it or not, I'll go ahead with it, to get a simple education package for schools. It doesn't have to be rocket science. You know, we've just seen 25% of kids don't have breakfast or hydrate. So we're not talking about rocket science here. So I think there's and the diagnosis of migraine is not rocket science either. So I think there's an opportunity here for a very significant impact, both educating not just the children, but the teachers. We did a qualitative piece of work with teachers, and they don't take these kids seriously. They think they're trying to get out of the lessons. So I think the focus of attention here should be simple interventions that can be delivered in a school setting. And that's what I'm going at the moment.
Right about that, Dave. If I may interject here, we are still stuck, you know, having spent 30 years in the field. David, you've been around in the field longer than I have even, and we're still stuck with nobody takes migraine seriously. The diagnosis is not made properly. I remember when my daughter, who's now 28, was at secondary school, I was well aware how many of her friends were experiencing migraine, even went to the High Mistress and said, you know, can I give a talk to the girls about managing migraine? They weren't interested. They were far more interested in you know, other gender issues than they were about the basics of managing migraine, eating regularly, and all those things which, you know, David, as you say, if we can get to young kids early and get effective management on board and recognition of the problems, that is just going to make such a huge difference to how these young people manage migraine when they're older. I'll shut up now.
Well, no, thanks for that. I think there's two buttons to press, because I've been involved with the school. I had the ideal circumstances to move this agenda forward since we did that initial study in 2008. I've been on the board of the governors, I've been chair of governors, I know the school intimately, and I have still yet to make an impact all these years, despite ideal conditions. There's two buttons to press. First is the mental health button, because we've shown again that there's significant comorbidity with mental health in these young people. But the button I've got now to press from this latest study, I've shown that it reduces their school performance. Because what schools, I'm afraid, are focused on is exam performance. That's what they live and die for. And if you can show them that these young people with headache have a reduced performance in school, I think they might start waking up to the need to do something about it. So I think those are the buttons to press.
Good idea. Yeah, that's a very good idea.
We have one question actually on Pizotifen. You mentioned that you find Pizotifen very useful in children. Is there an evidence base for this, or is this anecdotal?
It is totally anecdotal, but there's no evidence base whatsoever for Pizotifen.
But is it the case that the right trial just hasn't been done?
Yeah, the right trial hasn't been done, and it will never get done.
Okay, but is weight gain a problem in these children that you give the Pizotifen to?
Well, it can be. That's one of the major side effects, and they're obviously very sensitive about weight at this age group. So you have to tell them about that, and that you have to warn them about it. But you know, it might be my bias, but observational bias. But I've always found it very useful. Actually, perhaps it's the way you've got to sell it as well, because we're not just giving this; we're also giving the placebo with it as well. If you're passionate about headache, you're selling a placebo as well. So, you know, who knows? It might be all placebo.
No, definitely. Well,
I don't think it's not. I don't think it is.
Okay.
Well, migraine in children is a very important topic. We all see lots of migraine patients, and I always ask people when their migraine started, and a good chunk of patients say that their migraine started in their early teens. I'm always surprised how many people say that it started sort of around the age of 7 or 8. So like David said, it's very important that we recognize this from a very early stage and educate patients, because moving forward they're likely to benefit. So I'd just like to thank our panelists this evening, Dr. Kay Kennis, who's had to leave us a little bit early, Professor Anne McGregor, and Dr. David Koenig. Thank you all very much for giving excellent talks this evening on migraine. And I will arrange another webinar probably sometime in March or April, and I hope people listening today can join me. Everyone have a good Christmas and stay safe. Thank you very much.
Thank you. Bye.
Thank you. Thank you
Bye
very
now.
much, Ben.
Thanks, Ben.
Bye, everyone.
Bye.